to this session on risk stratification and prevention in ductal carcinoma in situ. It's chaired by Professor Jens Huber from Ulm and myself, Jonas Berg from the Karolinska. Ulm, as you know, is very famous for that Albert Einstein was born there. So we hope that we can give a session of high intellectual standards. So by that, it's a pleasure for me to present the first presenter, Dr. Fraser Symmans from MD Anderson. You will discuss risk stratification in patients with ductal carcinoma in situ. Welcome, Fraser.
Thank you very much. It's a pleasure to be here and to participate in this very important meeting. So this is the title of my presentation this morning. And these are my disclosures. None of them are directly relevant, but some of the work on sensitivity to endocrine therapy could potentially be relevant someday. So this is a schema for invasive breast cancer that I've long found to be helpful in terms of thinking about how the state of differentiation or grade, components such as proliferation, endocrine sensitivity, and HER2 amplification all sort of fit in, and also how we can think about the way we semi-quantitatively stratify them in routine diagnosis, and how we quantitatively measure their combination through phenotypic gene expression assays such as the recurrence score. And I think it just helps to put that in perspective. And if we apply that sort of simplistic schema to intraductal carcinoma, we see some subtle differences which I'd like to point out that are really part of the nature of DCIS itself. First of all, there is really a component of the phenotype that so quickly develops as invasive disease that it really very rarely presents as pure DCIS in a diagnostic sample. The frequency of DCIS that is triple negative, for example, is around about 6 or 7%, as opposed to about 17% in the invasive setting. So some of the most aggressive cancers just bypass DCIS by the time we find them in the clinic. Secondly, the phenotype of HER2-positive breast cancer loves intraepithelial extension and proliferation, and potentially lingers in that phase as it finds a way to become invasive. And in doing so, as a typically high-grade DCIS, it generates a lot of necrosis and calcification, and so we find this mammographically, and so there's a slight overrepresentation of HER2-positive high-grade DCIS as a factor of this intraepithelial phase of the disease. For example, Paget's disease of the nipple is essentially always HER2 positive, and that represents the most extreme form of intraepithelial spread. So that's a small difference. And then thirdly, I'd like to point out that we have these lesions that we call low-grade DCIS, where I think collectively as a community, we've come to the understanding that all of them are possibly not true cancers, but we really struggle at the individual patient level to identify when to say this is not low-grade DCIS, even though it looks like it probably might be, and to say that definitively for an individual diagnosis. The criteria pathologically between atypical hyperplasia and low-grade intraductal carcinoma are nuanced and subtle and take years of training, and there's lots of inter-observer variability, and this creates a slight difficulty for the field. Looking at these are somewhat older data, but looking at the SARE experience of intraductal carcinoma diagnosis rates, a rapid increase with the advent of mammographic screening, a plateau that has actually still continued even today, perhaps beyond the time wherein that initial catch-up phase of mammographic screening implementation, to the point where we really feel, I think, that there are lingering diagnoses of DCIS that might not really be DCIS itself, unless there's some other epidemiological pathogenetic factor that we're not aware of that is driving greater frequency of DCIS, and I don't believe that to be the case at this time. So I pointed to the topic of diagnostic challenges in the setting, particularly of low-grade DCIS, and I think this population health-based approach to the problem, published by Elmer et al. In JAMA a couple of years ago, is quite a good study for this purpose. There were 240 randomly selected cases of pathology, randomly assigned into 4 groups of 60 cases each. 115 pathologists were randomized to be in a group and to evaluate 60 cases, and therefore there's a whole lot of randomization in the study design. And the pathologists' diagnoses, they came from all over the practice setting, were compared to a consensus interpretation of 3 experts, and they were not always unanimous. And what was found in this study was that the agreement rates between the pathologists in practice and the consensus interpretation of the 3 expert pathologists were such that when the expert pathologists felt that the diagnosis was DCIS, in 13% of the time, the practice pathologists had underinterpreted that, meaning they were probably calling things atypical hyperplasia where the experts thought it was DCIS. Conversely, shown in pink, where there were 17% of cases where the experts felt it was atypical hyperplasia, but the diagnostic pathologists in practice had called this DCIS. So put together, there's really a 30% disagreement rate in that nuanced boundary between atypical hyperplasia and DCIS, and those will be the low-grade DCIS cases almost certainly for sure. In fact, one of the conclusions of the manuscript was that the most difficult cases were the low-grade DCIS in terms of agreement between pathologists. And in part, this overlap in these 2 entities is a factor of the molecular pathogenesis. Now, there have been many studies over many years using different technologies to sort of lay out this framework, and they all consistently show a very similar pattern, and I've just picked one of the reviews as an example. But basically, usual ductal hyperplasia, flat epithelial atypia, atypical ductal hyperplasia, atypical lobular hyperplasia are all part of the field effect that ferment low-grade DCIS and the pathogenic extension into low-grade invasive disease. So that is really why we have so much confusion between these proliferative lesions and these neoplastic subset. And they're often part and parcel, side by side, in the same tissues, in the same field. On the other hand, the pattern of invasive and intraductal high-grade pathology is far less of a field effect as we understand it. We see these columnar cell changes, which we can call African hyperplasias in this particular review. But other than that, we often see the high-grade disease just there in amongst otherwise fairly normal-looking breast tissue. And so the molecular pathogenesis of low-grade DCIS is almost certainly an estrogen-driven pathogenic pathway, whereas for high-grade, it's essentially other molecular pathogenic drivers. This is important, I think, for the strategies of de-escalation of treatment, as well as for understanding the discordance between atypical hyperplasia and low-grade DCIS. Because as we think about de-escalating the treatment of low-grade DCIS, we really want to think about these 3 elements. That there would be a low risk of there being undetected invasive cancer when the targeted biopsy shows low-grade DCIS. That there'd be low risk for ipsilateral local recurrence without usual local therapies, i.e. that the natural history prognosis be favourable and indolent. And that there be the potential to benefit from a preventative treatment that were well tolerated. giving an alternative management approach to current standard treatment. So, looking at the rate of upstaging to invasive cancer when the biopsy shows intraductal carcinoma and a subsequent surgical management occurs. Here's a large pathologic experience, retrospective, showing that the upstage rate for low-grade DCIS and intermediate-grade DCIS in a routine practice setting is 7%, 5%, and is lower than seen for high-grade, which was 12%. Furthermore, the distribution of the stage of the invasive cancer that is found tends to be more advanced invasive cancer in the high-grade DCIS on biopsy as opposed to the low-grade and the intermediate grade. And it tends to be in low-grade, intermediate grade more frequently ER positive, whereas it's a 50-50 for the high-grade DCIS cases. So the concurrent invasive disease is less aggressive and arguably better managed by hormonal therapy in the low-grade DCIS cases if there happens to be, in that small proportion, invasive disease. And in a different experience, this was another 297 patient study where the patients, this is not part of the Loris trial, this is sort of like a practice, a what-if analysis using eligibility criteria for Loris, showing a slight difference in the cohort with, again, low upgrade rate for grade 1 DCIS, but a slightly higher upgrade rate for grade 2. These may be cohort differences, I suspect. And the differences according to whether the surgery was mastectomy or lumpectomy are obviously confounded by the clinical, radiological, and surgical reasons for doing a mastectomy in selected patients in routine practice. Clearly, the higher risk patients are being identified through other means. And it's still in this analysis, in a different analysis now, 307 cases with vacuum-assisted core biopsy, then surgical resection. Again, a low rate, 7% for the low grade and intermediate grade of upgrade to invasive cancer, and a much higher rate in the high grade cancers. And again, making the same case that the upstages were far more likely in the hormone receptor negative disease. So high grade, hormone receptor negative being the higher risk for there being concurrent invasive disease not detected at the time of biopsy and radiologic diagnosis. So in terms of the prognosis with local therapies, building on long-standing experience with the Van Nuys prognostic criteria and the variables that go into the well-established nomograms that are widely used, this analysis of SEER data from Segara et al. Summarized the three main parameters, which are age, size of the radiologic lesion, and histology, meaning histologic grade, into a 6-point score with a 0, 1, or 2, according to the increasing severity of risk for each of these parameters that you can see here. And these are not from randomized trials. This is a population-based analysis. Some patients did not receive radiation therapy after breast cancer conserving surgery, and there was no difference in the probability of there being a local regional relapse in the patients who were of the lowest risk using these parameters of age, size, and grade. A different population-based experience from the Netherlands took on a slightly different approach, but showed a very similar effect, and also identified a very interesting finding that in the younger patients, that for the patients who had breast-conserving surgery, either they had it with radiation in yellow or without radiation in blue, that it appeared in the younger patients that there might be a temporary benefit or not a permanent benefit from the use of radiation, as opposed to the older patients shown here, both in the earlier experience on the left and in the later experience on the right. Of course, there was no influence on the contralateral invasive breast cancer recurrence in this patient population, and it should be pointed out that the authors clearly explained that in the Netherlands, hormonal therapy is not routinely used in this setting. A different registry from the ECOG 5194 prospective trial, wherein patients with grade 1 to 2 disease could have a lesion less than or equal to 2.5 centimeters, and patients with grade 3 less than or equal to 1 centimeter. So two cohorts of different grades of different risk groups, but both considered to be sufficiently low risk clinically to be candidates for a no radiation study, showed that in the grade 1 patients there was a much lower ipsilateral breast tumor relapse rate than in the grade 3 patients, even though the grade 3 DCIS lesions were obviously a lot smaller. And there was no difference in contralateral. So grade matters a great deal. So can we measure grade in a different way with a gene expression signature? You're well aware of the DCIS score, which is a modification of the recurrence score for use in DCIS. And it's interesting to think about how this was developed as explained in the manuscript. So the distribution of expression of the 21 genes was evaluated in a cohort of DCIS samples that were not annotated for any kind of outcomes. And then from there, in the early invasive breast cancer population, where from the tamoxifen versus no tamoxifen B20 study, the genes were identified that were prognostic and unrelated to the use of tamoxifen. And the rationale behind that was that tamoxifen is not widely used in DCIS. So really the point of describing these details is that the objective was to look for a pure play prognostic signature unrelated to endocrine sensitivity. And the genes that popped out as being strongly related to prognosis were, of course, the proliferation genes, progesterone receptor that had been long established as a prognostic marker in early breast cancer, and GSTM1. And so those are the 11 genes along with the reference genes in this score. It's a balanced score that is then scaled to a continuous range from 0 to 100, and the cut points for low, intermediate, and high groups are shown in this slide. And then, of course, this was applied to the ECOG study data. And as you will be familiar, for any ipsilateral breast event, there was a lower rate in the patients who had a low score with the DCI score. And the argument at present is whether 10.6% 10-year risk is sufficiently low to be actionable. This, for the invasive ipsilateral breast event, was 3.7% in this population. Clearly, this is needing a little bit more validation, and a recent publication combined the Ontario DCIS cohort, the patients who had breast-conserving surgery without radiation therapy, with the E5194 cohorts, increasing the numbers by a further 446 patients. And shown here from that manuscript is, I think, the most important point, was that for the tumors that are small and in the older population, arguably the postmenopausal population, there really was a very low rate at 10 years of local recurrence or invasive local recurrence. The previous data I showed you were at 5 years. This is 10-year follow-up data, and these rates are impressive in the subset of combined clinicopathologic and genomic criteria. I think that's an important point for risk stratification. A recent publication looks at a new approach called the decision score assay. This combines a series of immunohistochemical markers. The work was mostly done through tissue microarrays, but in a large population of patients who receive breast cancer conserving surgery plus or minus radiation. Now, the data that are published here, I'm not showing the clinical outcome data. They are cross-validation data from this discovery cohort. And the point here is that this is, I think, promising, but not validated in any independent sense, and we'll await further studies of that. My personal opinion is that it's good that there's a new interesting approach. I think there'll be some challenges with the immunohistochemical quantification, but I may be proven wrong. Now, with respect to chemo prevention and hormonal therapy, this is, I think, for the low-grade lesions, a particularly promising approach. There are some challenges with respect to adherence and the patient's personal perceptions of their absolute risk, the absolute benefit, the duration of treatment will all influence adherence, which is already currently at around about 50% when the patients agree to start. And then I think philosophically, what are we trying to treat with the hormonal therapy? Are we treating microscopic residual disease? Are we treating the pre-malignant field effect that I described earlier? Or are we treating bilateral future risk of invasive or in situ disease in either breast? In a way, it doesn't matter, but I think it is helpful to think about what sort of risk we're trying to understand and what sort of risk we're trying to reduce. We know from the SEER analysis from Steve Narod's paper a couple of years ago that even though the breast cancer specific survival is very, very good after DCIS, there is a significant difference over the first 10 years between ER positive DCIS and ER negative DCIS, but as we get to 15 to 20 years, that slowly disappears. We do know from this very important NSABP study, the prevention study with tamoxifen, that the breast cancer-free survival is significantly reduced in ER-positive disease. And the UK ANZ DCIS trial clearly showed that the use of tamoxifen reduced ipsilateral and contralateral events. So the summary of contemporary risk factors is that for the upstage to invasive cancer, it's grade, hormone receptor negative status, and larger size. It's pretty much the same along with younger age for local regional relapse, and the prognostic risk from DCIS score adds a degree of precision to that. For benefit from radiation therapy, I think Shelley's really going to talk about that, and for benefit from hormonal therapy, right now we have hormone receptor status. So as we look at our schema, we're really talking about the prognostic elements are becoming better defined, but at this point I think we're a little underwhelmed in terms of what we have for the endocrine dependence, particularly as we think about hormonal therapy as a chemo prevention strategy for these low-grade patients. The COMET study will address that, and the LORD and LAURA studies are clearly going to address the low-risk prognostic question in terms of observation. So to summarize, high-grade DCIS there's significant risk, and from a risk stratification perspective, it requires surgery, radiation therapy if breast-conserving surgery is performed. The challenge is to reduce overdiagnosis and overtreatment of lower-risk lesions. Some are inert and probably not cancer. We struggle to recognize who they really are. The principal biological target, in my opinion, is likely to be estrogen dependence. Prognostic tools will need to more accurately identify absolutely very low risk that is actionable, and we currently lack strong data for endocrine therapy to replace other treatments, but I think the trials are definitely leading us in the right direction, particularly Lord Loris and Comet. And I think we should keep an eye on the future in terms of what is the next biological target after endocrine therapy. Thank you.